MDS stands for myelodysplastic syndrome. It's a rare bone marrow disorder where the bone marrow basically doesn't produce enough healthy, normal cells, and eventually the disease can progress to leukemia. So when I think about children with MDS, it's quite different than an adult. Most children are picked up during their well-child checkup. Many times there's not even something obviously wrong with the child. The parents would bring the child to the pediatrician and blood counts are done, and surprisingly there might be abnormalities. That's how many kids present to us. One of the abnormalities we commonly find in children is a low platelet count, which is a bit different than adults. When we look at the bone marrow studies of these patients, which means we're looking at the place where the blood cells are made, a children's bone marrow with MDS looks quite different than that from an adult. There's very few cells left behind that make normal blood cells, and the ones that are there could be looking very abnormal. In adults, we tend to see a very busy marrow with a lot of cells that are trying their best to do a right job, but are not very effective in it. The other thing we find in children much more commonly in adults, and that's really something that has changed a lot over the years, is that many children have a genetic predisposition. That means we find an underlying broken gene, a piece of information that gives them a higher risk to develop MDS compared to other children, which is very different from adults, where we think about that the MDS occurs as an accumulation of risk over a lifetime. I'm really excited about how pediatric MDS has changed over the years. And while our treatments have not drastically changed in the approach, most children are still cured with a bone marrow transplant, and this is what really our treatment goal is. We want to cure the children to give them a long, lasting life. But our treatment approaches have gotten better. So transplants have gotten much better over time, and we are much smarter making the right decision for each patient, what the appropriate and best way to transplant the child is. But in addition, there are some other agents we've used a lot in adults, which are hypomethylating agents, that we haven't used as much in children because we often tend to go to transplant quickly. But I think nevertheless, we're starting to learn how to use these agents better in children as well. And I think in the future, we have a lot more capability on including those agents and really knowing how to best use them in children and what the benefits will be. When I talk to patients and families, I think the most important thing that I can tell them is keep on asking questions. Be curious. You're the one that knows the child the best. There's nobody else in the world that knows your child better than you do. And ask the right questions about what feels unsettled to you, what is unclear. So challenge your physician if you don't get the answers you want, and the answers that help you understand what is wrong with your child. And don't be afraid to seek out expert opinions. You know, we all need a little help at times, and I'm not an expert in everything, so are my colleagues experts in other things. So it's good for us as physicians to encourage to ask each other for help and encourage families to ask for help and additional information, because at the end of the day they need to be at best peace they can with the decisions moving forward. And these are hard decisions to make, and we want to make sure families are not alone.